Hello everybody, we're here at the Andrews Institute today. I'm Dr. Brandon Winchester from blockjocks.com, and I will be demonstrating today a left-sided continuous femoral nerve block catheter for a left knee osteochondral defect repair using an allograft into the knee. So it is typically around here more commonplace now for knee surgeries that warrant a continuous catheter to have adductor canal catheters placed at about the mid-thigh location. We found, though, that for these allograft implantations that patients have better pain relief with a continuous femoral catheter. In particular, some of our younger patients, the teenagers in particular, seem to have better pain relief with the femoral catheter, hence that's what we'll be doing today. So what we're going to do first and foremost is demonstrate the step-by-step process of doing this block using a Contiplex 360 custom catheter tray for equipment-wise, in addition to our Bebron and Philips Experius ultrasound machine. But secondly, it's a nice opportunity to demonstrate a new video technology that we've been using the last several weeks here at the Andrews Institute called 360 video, virtual reality video. So what we're filming on right now is essentially a 360 two-camera spherical video whereby as long as you're watching from an app like YouTube app or Vimeo app or Facebook app, you'll be able to pan around the room, look left, look right, look down, look up at all the things that, that this room has to offer, ranging from the ultrasound screen to the catheter tray, to the practitioner, to the block nurse, etc. So take advantage of this technology and take a look around while we're doing the block, and it's more of an immersive, really virtual reality experience that we're pretty excited to participate in. So we'll get started here in just a minute by prepping the area that we'll be working. All right. We'll start by placing our sterile gloves and prepping the groin widely with chlorhexidine scrub. Okay. We've sedated also with a combination of Versed and fentanyl, which is my drug du jour combination for continuous catheters. Typically I'll get by for single injection nerve blocks with just Versed. For catheters, being that it's a larger puncture, larger needle, I find that adding a few cc's of fentanyl, anywhere from 0 to 100 mics of fentanyl to the anywhere from 3 to 5 milligrams of Versed is a good combination. So using our clear fenestrated drape that comes in our custom tray, we'll place the fenestration nice and lateral so that we can insert a little more lateral than we would for a single injection nerve block, hence allowing us to have a little longer pseudo tunnel from insertion site to femoral nerve. My next step is to flush through the Contiplex Echo 360 needle local anesthetics. In this case, it's going to be 0.5% ropivacaine plain. And we'll also connect our nerve stimulator. As is typically our practice, we use a dual guidance technique with a combination of ultrasound and nerve stimulation. And then we'll use a sterile ultrasound gel placed onto the Experius linear wide high-frequency transducer, but we will hold it through the plastic drape, maintaining a sterile insertion site separated from a non-sterile scanning location. So our initial scan is aimed at identifying the femoral artery, which is nice and pulsatile there, left side of the screen being medial, right side of the screen being lateral. If I scan a little bit more to the left, a little bit more medial, I can see compressible to the left side of that artery is a nice femoral vein, highly compressible, and of course the femoral artery is highly pulsatile. If I go a little bit more down the leg, a little more distal, I can see the femoral artery splits into superficial and deep branches there. So when doing a femoral block, you want to scan proximal to that and ensure that you're just cranial to or just proximal to that split. You can see right to the right of that femoral artery, just adjacent to it, is the femoral nerve, taking on its usual kind of elongated diagonal shape. We'll go ahead and infiltrate with a skin wheel here. Now you're going to feel a bee sting, okay? Big pinch on 3. 1, 2, 3, pinch. Notice we're farther away from the transducer than we would go with a single injection block, like I said, to try to have a little longer distance from insertion to nerve. Okay, and we sort of hub the needle and just create a nice infiltration track. Okay, we'll be coming from right to left on the ultrasound screen. Very superficial on this particular young patient. We're going to see our 18 gauge Contiplex Echo 360 needle approaching from right to left. And as I pop just above the femoral nerve, oftentimes we'll feel a little bit of a twitch in the femoral territory, down the quadriceps to the patella. I haven't quite gotten to it yet, but I'm going to scoot a little bit deeper and go just under the femoral nerve. And at this point, you could try to tease out a strong twitch. We don't rely heavily on twitches, although there's a twitch there that's going all the way to the patella that you can actually see. If I reposition myself a little bit, I actually see that patellar snap there. But from this point, we're going to use a multiple injection technique, so the patellar snap's not so critical with this multiple injection technique. We're going to go ahead and put half of our total dose of up to 30 cc's below the nerve and the other half above, and then we'll lay the catheter above the nerve. So go ahead and aspirate in very slowly, give 5 cc's. We're going to inject 5 cc's below the femoral nerve. And you can see if I scan up and down, you can see a better contrast deep to that nerve now. In this next 5 cc's, I'll inject just cranial to where I'm injecting and where I see the needle, so I'll be able to see the nerve push away. So go ahead and give the next 5 cc's. See the nerve actually pushing up away from the injection.
See it.
Okay, so that's 10 cc's under the nerve. I'm going to pull back and just hydrodissect just over the nerve. Aspirate and slowly give 5 cc's there, please. You can see the local anesthetic spreading over the top of the femoral nerve there now.
It's 15. I have 5 left in this syringe, or I can get more.
Okay, you can see a nice femoral nerve just below my insertion. Right, it might be below my needle. Now I do see a little bit of a fascial plane above the femoral nerve, so I think I always try to decide which plane is going to be better for me. The plane below the nerve, as far as a nice hydrodissection plane, or the plane above the nerve, below the nerve or above the nerve. In this case, the hydrodissection plane actually is a little bit better below the nerve, so I'll probably just lay my catheter under and past the nerve, as opposed to my usual over and past. So with my last 5 cc's, we'll just go a total of 20 on this one. Last 5 cc's, go ahead and aspirate and inject slowly. See the femoral nerve pushing up nicely there.
4.
All right, so I'm going to go ahead and lay my catheter just under and past that femoral nerve. I'm going to hand off the transducer. Very carefully keep that needle tip still. Disconnect my tubing. And thread my catheter. Okay, catheter is emerging out the tip. We'll go ahead and find that needle again. There we go. Catheter tip's emerging out at the tip of the needle, and I'm just essentially just laying it where it lies. As I back my needle out, just laying it where it lies. It's intended to be a little bit under and past the nerve. Usually I try to go a centimeter or less past the nerve. And then now that my needle is about maybe half to 2/3 of the way out, I'll change my needle trajectory, redirect my bevel, and just lay a couple of additional centimeters subcutaneously. So if the catheter gets tugged on at the skin, it's not as likely to dislodge the tip. Okay, and we're about 12 at the skin or so, thanks to that extra slack that we left. Okay, so we have our usual test dose, lidocaine 1.5% with 1 to 200,000 epinephrine, a little under 3 cc's there. And we'll just inject about a half a cc just to clear enough space to adequately aspirate. Aspirate slowly, continuously for a few seconds, see that there's negative aspiration to heme. And then we'll look for spread just under and past the femoral nerve, under that femoral artery there on 3. 1, 2, 3. See a good spread right there. If you're ever in doubt and don't see particularly good spread, you can turn your plunger down so that the half a cc of air all goes in at once on 3, and you'll see a nice reflective, bright white air injection. And scan a little bit medial so I can see the left side of the screen a little bit more. There we go. 1, 2, 3. All right, a little bit of a flash. You can see that on the screen. So we are right where we want to be, just under and past the femoral nerve. So I'll go ahead and give the rest of that test dose. Keep an eye on our baseline heart rate in the low 70s, see if there's any significant change, indicating that epinephrine was absorbed intravascularly or injected intravascularly directly. So go ahead and maintain that view there and take a picture. Freeze our image. That's good. So all we have left to do is just secure the catheter and we'll be all set to go. So notice I haven't let go of the insertion site because that catheter has a tendency to want to wind itself out, especially these shallow ones. So I've kept my sterile chlorhexidine sponge just so that after that ultrasound gel, which is sterile ultrasound gel but was on the non-sterile part of the field near the insertion site, I'll give that one additional wipe with that chlorhexidine just for a little extra sterility. And to offset the unstickiness of the ultrasound gel, I'll use a little mastosol bullet widely around the insertion site to make the dressing stick better. Using one of the sterile 4x4s that comes in our custom Contiplex tray. Just dab all that mastosol to make it stickier, quicker. Now, equally important to that step is the application of skin sealant. In our practice, we use Histocurl skin sealant, and usually about 3 to 4 drops on the insertion site is all that are needed. And I just use this needle cap to help spread that Histocurl around the insertion site, and that should be excellent. That'll help seal the hole, make leakage less likely. And just to be extra special cautious about leakage, I'll put a couple of 4x4s folded on themselves between the tegaderm and the insertion site as sort of a pressure dressing. Prior to doing that, I'll put a few steri strips on in a star-like pattern, leaving the insertion site just a couple of additional extra steps to try to keep that catheter from getting tugged on and dislodged. So it works so hard to put these catheters in, you don't want them to get yanked out on the floor or after they go home, in our case, since we're outpatient. So I'll take the remaining sterile 4x4s in the custom Contiplex tray, fold them once, fold them twice, take our large tegaderm, place that sterile 4x4 folded twice right in the center, and apply that large tegaderm over it. You oftentimes have to burp a little bit of air out of that dressing. And that's what I'll do here. Everything's now sticking to me, of course. Gonna burp some of that air out in all directions. And this concludes a left-sided continuous femoral catheter placed with ultrasound and dual guidance with nerve stimulation in plane from lateral to medial in the short axis for a left knee osteochondral defect allograft implantation here at the Andrews Institute. Thanks for watching, and stay tuned for more blocks on blockjocks.com.